last in the series of Malignancies in Women's Health, and it's part 2 of breast cancer. We're going to discuss the medical and nursing management once breast cancer has been diagnosed. We begin with the surgical approach, and this has been changing over the last several years, where we are trying to spare the breast as much as possible and do a simple lumpectomy. If we can't do the lumpectomy, then they can do a simple mastectomy versus a radical mastectomy. And when you look at the picture in the lower right, you can see the difference. A simple mastectomy is just taking breast tissue and the lymph nodes, whereas the modified radical or the radical is going to take some of the other tissue that's there, including part of the muscle flaps. Once they do a mastectomy or radical mastectomy, they may insert tissue expanders so that she can have reconstructive surgery when all is said and done. Some women opt not to do this. They don't mind having the scar and having no tissue in there whatsoever. For more advanced stages of breast cancer, they will also do the sentinel lymph node biopsy to detect any type of potential for malignancy. Once the surgical approach has been completed, we get the patient involved with the medical management, which includes radiation and or chemotherapy. Most women do have radiation for breast cancer. Now, if their type of cancer is receptor positive, then we're going to treat them with medications like tamoxifen that actually addresses the estrogen receptor. And then we have the use of Herceptin, which is a biologic for the type of cancer that is HER2 positive. For those who are taking tamoxifen, we also want to suppress their ovaries. And we can either do that surgically by having a bilateral oophorectomy, or they can take a medication that is a GnRH agonist so that the ovaries don't function, and that medication is Zoladex. Now, in terms of what do you need to know regarding medication, you should be familiar with Herceptin, tamoxifen, and Zoladex. But you don't need to be focused on the chemo agents themselves, but you need to know what are the side effects of chemotherapy in general. And that brings us to our nursing interventions. So you're going to see these patients in the immediate post-op period. For those of you planning to go to the OR, you're going to see them in the pre-op area. But post-op, our focus is going to be on pain management, wound care, monitoring their drains. These women will have drains, and I have some pictures that are going to be coming up where you can see how many drains can be put in place. Remember, when we take the lymph nodes and the lymphatic drainage system, there's going to be a lot of fluid accumulated that needs to go somewhere. And so they're going to insert a variety of JP, the Jackson Pratt drains. And so you need to be looking at the drainage. You need to be measuring the drainage. You empty the drains when they are full. So when the bulb is all the way rounded, you know that it's not doing any more suction. So you need to empty it and then roll the ball so that I roll it like as if I was going to roll up a cigarette paper, and then close the top and then let go, and now you're creating the suction. Women will have ports placed sometimes at the time of surgery, or they're going to go back later and get that in for chemotherapy. So if they have also had a port placed, then you need to do the post-op care of the port site itself. Women will be going to radiation therapy, and so this is on a weekly basis. They go in and they do a laser-directed therapy right at the area of where the lump was. It can create burns, as you know. I'm sure that you heard this from Professor Kracharski in second semester. And then the women begin chemotherapy. Some will be admitted inpatient for chemotherapy, but most of this is done in a hematology-oncology practice. We need to address the body image issues. So some women, knowing that they're going to undergo chemotherapy and they're going to lose their hair, we'll go ahead and just shave it. And that gets them used to it. And as a woman is going through chemotherapy, if they've opted not to shave their hair and we have them in the hospital, please take care of the way they look. When you see hair on the pillow, take it away and then try and do gentle brushing to get rid of the hair that's fallen out so that it's not all clumped and matted. And we want to start discussing what are their breast reconstruction plans. We don't do this immediately. This woman is still trying to get used to the fact that number one, the breasts are gone. Number two, you have to have radiation. Number three, I have to go through chemo. And oh my God, I have cancer. And what does this mean about my longevity in the long run? The good thing about discussing breast reconstruction plans is it gives them hope that they will get through this and that they're not going to die from it. We can't always predict who's going to die and who isn't going to die. We want to give them as much hope. Let's get back to the immediate post-op care. When they are in the hospital after surgery, we want to keep them in a semi-Fowler's position so that they can promote gravity drainage. Elevate the arm on the affected side. If they've had a bilateral mastectomy, we need to elevate both arms. You want to promote early ambulation to prevent all of the complications that can occur with any type of surgery. Common expected side effects of any surgery are pain, infection, bleeding. And so the infection doesn't necessarily have to be at the incision site, but we can have pneumonias and urinary tract infections as well. So we want them to be using their incentive spirometer. We also need to start getting them to move the extremities. We put them through range of motion exercises, and they start off just by flexing and extending the fingers. When they've had a radical mastectomy, the pain is very intense, and so they don't want to move anything. And just one day of not moving stiffens up all of the joints and the muscles. So we get them to flex and extend the fingers, put the wrist through flexion, extension, and then also circle it to keep it moving. Flex and extend the elbow, lift up the arm, and that's going to be the thing they're going to complain about the most, is having to lift those arms. And you'll have to assist them with movement for the first couple of days. Some of the post-op issues that can extend throughout their life is the presence of lymphedema. And so when you look at the picture on the right, you can notice that not only is the skin discolored on her left arm, but look at the size of it. It's not quite double the size, but it can be triple the size in a patient who has profound lymphedema. The picture on the bottom is depicting the compression garment. And this is very decorated because it's reminding us as healthcare providers that we should not do anything on that arm. We do not take their blood pressure, we do not draw blood, we do not start IVs on that affected side. So if they've had a double mastectomy, we have to think of where are we going to be drawing blood? Where are we going to be taking the blood pressure? And so we're going to have to use the lower extremities. So additional care of lymphedema is going to be physical therapy. And our physical therapists are so good at being able to manipulate tissue and get the fluid to move into surrounding lymphatic structures. And so we get them involved, and they can also go on an outpatient basis. So we want to get this woman, if she develops it early on, we can get a compression garment while we are in the hospital. Otherwise, they can go to a medical supply place. You can go online, you can order them. And they need to wear this all the time. So this young lady, and she looks really young, probably in her 30s, early 30s, who has undergone a mastectomy for stage 3C breast cancer. That's an aggressive cancer at such a young age. And she is showing us what her post-op chest is looking like. So underneath the bandage, of course, is the incision, but do you see all of the bruising? Because it's a pretty brutal surgery. In this picture, on the left, we only see 2 of her Jackson Pratt drains, but that is the typical drainage that you will see. If you look at the actual tubing, it's serosanguinous and it doesn't look as bloody, but of course when it collects in the bulb, it looks a lot bloodier. And then on the picture on the right, we can see that she actually has 3 JPs in place. So the one that's on the top right, that one needs to be drained. So you open up the top, you empty it out, measure the output, document it in the chart, and then you're going to roll it up, like I said, so that when you put the cap back on, you're going to see the suction where those other 2 are collapsed and concave. That's what you want it to look like. So she only has a peripheral IV at this point. You know that we do not access implanted ports until they're healed, and it can be like 1 to 2 weeks. They're pretty painful too. Another complication can be, because of the lymphatics, is seromas. So a seroma is just a large collection of serous fluid, and the fluid color is what you see in this syringe on the left. And so what we did here is give a local anesthetic, perhaps. I usually don't give them a local. I just go straight into it and withdraw the fluid. If it's beyond the 60 ml syringe, then the nurse practitioner or the physician will ask you for a thoracentesis tray, because it has a bag inside that has a capacity of 1,000 mLs. So the picture on the right is once again how in a hospital setting we just put a label on the side where we are not to do any blood draws, blood pressures, or IV fluids. And you can see that she has the port in place on the right side. So our discharge instructions, they're typical for any post-op procedure about the signs and symptoms of complications. And you should be well versed in that. And if not, go back to your first and second semester post-op complications lectures. So we do monitor for wound infection. It doesn't happen all that often. We want to give them their prescriptions for pain management and drain management. And so if anything is going to get infected, it's going to be the drain. And so you see what the normal drainage is supposed to look like. You show that to the patient so she sees what it's supposed to look like, and whoever else is going to take care of her at home. If they notice that they open up the cap and it is a foul smell, they need to call the physician immediately. Well, not in the middle of the night, but as soon as office hours are open, and they have to go in and we pull the drain. Another thing that they might see is that it's no longer that sort of clear but bloody drainage, but it's cloudy, or it starts having strands, and what you're actually looking at is pus. That also needs to be reported. They come in and we take out the drain. The patient needs to continue to exercise. The range of motion is critical for her long-term function. Address nutrition. They might be depressed, they might be in a lot of pain, narcotics will take their appetite away, but they need to have good nutrition for wound healing and so that they can endure the side effects of radiation and chemotherapy. Facilitate the appointments with the surgeon for post-op care and the oncologist. And an oncologist is usually in place prior to surgical procedures, but we want to make sure that they have the follow-up care so that the plan can be implemented as soon as the surgeon says, yes, you're good to go, let's get started. And then we reiterate what the oncologist and the surgeon has discussed with the patient at the bedside. So when you see them going into a room, follow them. Listen to the discussion of what's going on, because we tend to talk very fast. Our vocabulary is still over the head of the patient, and so you need to be able to interpret what was discussed and have the patient tell you, what did you hear, what questions do you have, and answer those questions. She may ask you your opinion. Eventually, you, especially if you're an oncology nurse, you're going to know the answers, but initially you're not. So you just defer those questions to somebody who knows. So breast cancer Prevention of things that we can modify in terms of our behaviors is important, but as nurses, we want to promote self-breast examination. Put the lecture video on hold for a minute and look through all the steps, because this is your role. You need to teach women how to do self-breast examination. So this ends the series of lectures on malignancies and women's health. Thank you for listening.